Hello everyone, welcome to the second episode of Retina Chat. Everyone, I'm Mohammed Ghunaim and with me is Dr. Mustafa Al-Manhali, and today we'll be chatting about a trauma case.
Hello, everybody.
So, my case is a 50-year-old patient. He had a blunt trauma and has presented to me with a white cataract and vision is hand motion. I did an ultrasound and it showed vitreous hemorrhage and a suspicion of retinal detachment. So first of all, let me ask you, how do you counsel these patients? Do you talk to them about the post-operative expected visual acuity? How do you talk to them?
Yes, trauma patients are a very specific type of patient that you have to explain and counsel them about visual prognosis and the difficulty during the surgery and all the options that you can encounter during IOL implantation, even cataract removal, and if it is associated with any retinal problem or any retinal diseases. So you have to explain the spectrum of the surgeries that you are going to entangle during the operation, and even the post-operative period for rehabilitation, or even the need for re-intervention for especially traumatized patients with this complicated kind of.
So basically, you just tell them that visual prognosis is not expected. You can't expect how much they will see after the surgery, and they may need multiple surgeries in the post-operative. Okay, so let's start the case. First of all, you can see that there's a dense white cataract and there's a subluxation that is appearing in the inferior part of the lens. I stain with the trypan blue dye, and we can see that there's a calcification and the rexus is very difficult. I can't complete a curvilinear circular capsular rexus, and there's an evident severe subluxation. So let me ask you, in these cases, are you a fisher or a diver? Would you let it drop and then dive into the vitreous cavity and complete the cataract, or fish and try to finish it in the anterior segment?
Definitely, I would like to remove this bulky white cataract from the anterior segment, even if I open an extra capsular and remove it with the capsule all in one package.
Yeah,
Rather than it drop and trying to use the phacophragmatome, or even using the phacoemulsification down in the vitreous. So trying to remove it from the anterior part is definitely the best option for me.
Yes, this was my decision because it's quite a dense nucleus. I need a phacophragmatome, and there's vitreous hemorrhage expected. There is a detachment, so I don't want to complicate the vitrectomy more and more. So here I'm trying to stabilize the capsule with the spatula and trying to emulsify the cataract, or try to prolapse it into the anterior chamber, but I couldn't. It's very deep, and I couldn't complete the surgery as usual.
Let me stop you here. Could you consider from the beginning to add trocars and try to do a lensectomy using the cutter, or
In this dense nucleus, no, I don't think it would work. If it's a younger patient and less dense nucleus, then okay, I would do
it's a
that.
very good trick that you did. That
Yes, I inserted the trocar and did a posterior assisted levitation to just prolapse the nucleus into anterior chamber and then continue phacoemulsification. So, do you use this technique often in such dense nucleuses?
actually didn't come to my mind before, but after your video, probably I may use it if I have this subluxated lens using the trocar incision. I used it before to try to use the 3 millimeter syringe to elevate the subluxated lenses, but using the trocar, this is really a very good trick that may be needed later on.
Yeah, I just discovered it by chance. You can you can imagine. So now I just finished the nucleus, and then with the cutter eating up all the the remaining lens tissue and the anterior and posterior capsules, just to make it easier to visualize during the vitrectomy. At this stage, do you do you insist on removing everything of the lens?
Yes.
Do you find it important to reach the zonules with your cutter to remove everything, all the remnants of the posterior capsule?
Yes. Actually, there is no need for any remnants for the capsule to leave it. So we're not going to implant at the sulcus or even any kind of intracapsular IOLs. Probably are going to using whether a Yunani technique or severe fixation or even
Yes.
artisan if you can repair this iris. So there is no need to remove. And the prognosis is much better when you remove all the capsule to avoid any anterior fibrosis that may cause ciliary body detachment and lead to hypotony, especially in these cases with trauma.
Okay, so now you're wondering what does this case have? There was no vitreous hemorrhage, no detachment, and the ultrasound was totally deceiving me. Did you encounter this situation before, that the ultrasound gives you impression that there is a severe posterior segment pathology and you just find nothing?
This is a very rare condition, but actually, yes. But the question, if you find that there is nothing in the posterior segment, there
Yes.
is no pathology,
Would
would
you
you
continue?
continue?
Yes.
From my side, yes, because if I did an infusion in the vitreous and I started to do like turbulence in this gel, so probably it's going to liquefy more. And in these cases with trauma, they may have any retinal peripheral pathologies that may lead to retinal detachment later.
Yes.
So I definitely would remove all the vitreous, do as you did the PVD, complete PVD, and screen the periphery well.
Yes, I will go back to this stage because during the posterior assisted levitation, we can induce vitreous traction and cause breaks. So this is very important at this stage. After completing posterior vitreous detachment, is to screen the periphery that we didn't cause any breaks. So I was particularly concerned with the area where I did the PAL to screen if I did any retinal tears or any vitreous traction that may cause a future problem. So yes, I agree. Once we're inside the eye, when we did hydration of the vitreous with the infusion, we continue all the way with the complete vitrectomy. Here I'm doing some indentation to make sure that I did a thorough job in removing the capsule and until the zonules. So here I'm injecting pilocarpine to bring the pupil down. But as we can see that there is some sort of traumatic midriase, and the pupil is not. Yes. So I'm dragging it with the forceps to just manually constrict the pupil as much as possible, just to prepare the eye for an artisan lens or an iris crow lens. Would you consider, by any chance, doing some anterior segment surgeon like doing iris hooks and then fixing the bag into
So
the
this
skin?
bag is completely compromised
Yeah,
due
due
to
to
trauma,
trauma.
yes. So there is no hope in this bag that we can salvage this
You wouldn't consider a
intra
CTS and a segment and
because the dialysis is more than almost 270, so we cannot guarantee that even we implant in this capsule that it may live long with this intracapsular. And actually the anterior segment trauma, as we have seen in the beginning of this surgery, that there was a posterior synechiae and even the traumatic megasis give you a clue that this anterior segment will not be stable later on if you implant the IOL in this compromised capsule. So there is no need to salvage or to do any job when you waste your time if you do a CTS or trying to suture this capsule.
okay, so I did the same thing and I put an iris crow lens. Here I'm doing a retro inclination technique. I'm putting a spatula through the trocar and pushing the iris downwards and upwards through the claw.
Can you stop the video here?
That's true.
So I'd like to just to highlight that implanting this kind of iris claw IOL, you have to change the orientation of the IOL
Yes.
if you are going to implant it in the anterior chamber or a retro.
Yes, exactly. We have to look for the curvature
Yes.
and aim at the curvature to be upwards in an anterior inserted iris claw, and posterior if it's
So the
posterior.
convexity of the IOL, if you are going to implant it over the iris, it looks it's forward to the cornea, and if it's
retro,
retropupillary, yes, the convexity is looking toward the retina. This
yes.
is to avoid any pupillary
Yes, exactly. So here in the right claw, I did it through a spatula, and the left one, the trocar is just far away from the claw. So I use the insulin syringe with a bevel down to enter the vitreous cavity, and then retroenclavate it again from posterior to anterior. Do you like this technique, or do you do it with the enclavator as it was first mentioned by the
Actually,
artisan?
I do it the same, but if I am planning to do this artisan, I would move the left trocar
Yes.
downward a little bit to 2 o'clock position, so I can use it to do this kind of
Yes,
implantation
exactly.
instead of using another implantation using
Exactly.
the insulin syringe. Yes.
Okay.
Let me ask you: would you consider before adding this iris claw lens, would you consider any iris suture or to treat this mydriasis?
If it was a little bit larger than this, the pupil didn't go down that much, I would do that. But just enough just enough meiosis for me to put the claw is enough. So I wouldn't just add more and more steps to the surgery. I like to do a quick and efficient surgery. So
With this degree of mydriasis, would you do an iridotomy?
yes, I would do iridotomy as long as I'm putting it anterior. I wouldn't do if it's retropupillary artisan. It's not mentioned that it's not mandatory to do a PI.
Okay, and you left your patient on what tamponade?
Just fluid,
Just a
nothing.
fluid.
Yeah. Do you do this often or just leave some air?
Actually, those patients, I never leave any patient on fluid. I just could leave them on half-filled fluid air exchange just to guarantee that the sclerotomies are at least safe the first few post-operative days, if not a complete fluid air exchange. But in this case, I don't know if just fluid would be okay because you have an anterior segment, even corneal incision to implant, and you have the sclerotomies. So, how did your patient do after the surgery?
It went fine. If I find that the eye is a bit hypotenuse at the end, I may inject an air bubble, but I wouldn't do a fluid air exchange and leave a large bubble. Also, I find that sometimes if I add air in these cases, it may push the IOL and cause some disturbance in the anterior chamber depth. So just if the IP is okay at the end of surgery, I may leave them on fluid. But this is a rare thing. I usually prefer, as you said, to leave some air inside the eye for the sclerotomy security. Okay, thank you everyone for listening to us. This was our second episode. Stay tuned for the next one. Thank you.
Thank you.